So now, without further ado, I think we'll just dive right into our US healthcare overview. Maybe this will help for a little bit of a compare-contrast with Hong Kong. Dr. Luke will... No problem, not starting yet. He'll be giving the Hong Kong perspective, and let's get started. I think some of you might have seen pictures or waiting rooms of hospitals where it's super crowded. People talking about healthcare being broken, the delivery system is not working for the masses. Some people who have good access or good coverage, how do we get that to be a universal thing? Is it a right or not? How do you afford it? So these are all issues for every country. The US also has long wait times. Well, how about that picture there? Not from the US. But experience in China, yes. I go to China a lot. I've gone, spent times in the hospitals for sabbaticals for months at a time. Seen a lot of different specialties besides my own. Definitely there are problems with wait times, but actually in my own clinic, I also get graded on patient satisfaction. We get surveys, and that's actually tied into reimbursement. And they show our scores relative to everyone else in our department, almost like a public shaming. And wait time is the #1 correlated factor for receiving a non-5, something that my students did research study on even in our own clinics at Stanford. So, but essentially the problem is that the population is growing in terms of older age across the whole world. People are living longer, and living longer means potentially more chronic disease. Chronic disease is expensive, especially if there's not a single cure. You can't just one and done fix it. You have to manage it over time. Oftentimes it may be behavioral, which is something that's very hard to manage and control, just like not eating a cookie if there's a cookie in front of you. So we all know oftentimes what's right to do, but it can be very challenging to actually do it. Then we have a lot of other sort of maybe institutional problems or system-based problems, things that relate to how you store records, how you charge for things, keep track of payments, what's transparent, what's not, how do you make it more efficient when you don't even know what you're working with and what's happening. And a lot of that stuff may stem from interoperability problems, like we have electronic record systems in the US, but none of them can communicate with each other. There's a reason to maybe even separate data. People want to hoard data, they don't want to release it to other people because they think it's valuable. So when you start fragmenting a system like this, it's very hard to be efficient and more cost effective. But that's maybe not something that could be solved in a week. It's something that you may not, it may be a very obvious problem and something that seems attractive as like a tech person to say, well, I'm going to just code it better. If the doctor wants that to be seen, I can just do that. But then there's a lot of stakeholder issues, a lot of other things that maybe there might be something easier to focus on rather than something that may be a very high governmental change or regulatory change or something that is not an easy thing to do at this stage. In any case, doctors sometimes are getting burned out. They're doing more for less everywhere in the world. And we want to empower them with technology. We want to use whatever tools we have to make their lives better, both the patients, the physicians, a win-win situation, so everyone can improve their health at a cost that's reasonable. But again, everything's relative. Every doctor probably complains in their own respective countries about how bad their system is. But when you compare across systems, then maybe you can see what's better in some places. So actually, in the US, I think doctors are very good, because I've been to doctors in many different countries. In terms of how the insurance and payments and who are all the players involved in healthcare, generally there's these 4 buckets. There's the patients themselves, you can consider them consumers or customers. There's the providers, which means the people who are delivering the services to the patients. There could be doctors, they could be ancillary healthcare providers, nurse practitioners, all different levels of service providers. And that's a clear interaction there. But then there's a third party that's kind of getting in the way, so to speak. Because normally when you do a transaction, you just buy something directly from the company that makes it, or the provider who does the service, like, I don't know, like your barber or something, you just pay directly. But here we have to involve a payment with a third party. So that's the third party system that makes it very complicated, which is it can be an insurance company, or it could be a government, or it could be an employer-based insurance, because they're involved in paying for that insurance rather than you paying the insurance yourself. Or maybe it could be a group of people getting together paying for the insurance if you own your own company. There's a lot of different variances there. And that part is sometimes not as transparent. What are they paying? What's the negotiated rate? Why are the rates the way they are? Who controls most of the patients? Who's on the plans for the doctors? How do you negotiate that stuff? So there's a lot of complexity there, and that also increases the price of the whole system. Because there's a lot of administration behind that, and a lot of things that are in place that nobody wants to change because they're taking their slice of the pie in terms of the overall healthcare costs. So then finally there's also the government, because basically people feel that healthcare, it's very hard to everyone to save enough money to save for their own insurance. So that's the idea of insurance, is that it really will cover a catastrophic thing by spreading the risk over many people. And the government has to cover the very, very poor people who don't have the opportunity at all. As well as what they set as their rates may affect the rates of which a payer or insurance will set. So you got these 4 pots. Did I make it already complicated enough? I see people still have their eyes open, so I didn't glaze you over too much. But essentially, doctors, patients, insurance, and government. And then of course there's all the vendors who are the companies that sell stuff to the doctors, whether that's devices, because we're innovating in the device, software, IT stuff, drugs, things like that. So that's more of a direct relation there. But again, there's a regulation that's involved, and how much payment you can get for that is also regulated through the government as well. It's not like you can necessarily set your own rates. Plastic surgery you can, things that are maybe not medically necessary, you can set your own rates, like you want to get LASIK, something like that. But for medically necessary services, then there's this whole complex negotiated rate that we don't need to go into too much detail. So generally, where's the total amount of money going in the healthcare spending? We talk about the healthcare spending becoming a larger percentage of the GDP, the gross domestic product, the US, like about 20%. And if you break down that money, it's basically going into hospital-based care, about 40%, this is in 2016. Physician and clinical services payment, about a quarter. And then there's this everything else, home health care, prescription drugs, nursing facilities, dental, etc. So that just gives you kind of a basic breakdown of the fractions, which actually haven't fluctuated that much over longer periods of time, even though the overall total pool of spending has gone up. So again, we already went over this, the aging population, more chronic disease. This is, have you seen these kinds of pyramids before? Aging pyramid. So most countries, developed countries, are sort of having this problem of this band right here crossing this line right here. So once, we call this the baby boomers generation, it's over 65, the number of doctors that we have to take care of that population will not increase fast enough for that number of people who are going to need more care. And so we're going to have a shortage, essentially. Because training doctors, predicting how many spots you need in medical school, medical school's training is 4 years college, 4 years medical school, 4 years residency, 1 to 3 years fellowship. How can you predict that many far years ahead how many slots you need for all the different kinds of specialties and things like that? So there's generally a lag time. So we're going to be hitting this crunch time soon. So that's where we need to be creative about what else can we do. Can we enable other providers to be as good as the providers that are specialists? Can increase the pool? The U.S. used to bring in doctors from other countries all the time to help get the shortages, especially the poor distribution of doctors, because as you know, doctors want to live where all the action is. They may not want to provide in the rural areas, but patients are all over evenly distributed, so you have an access and demand problem. So these are very high system level problems. It's not the things that you may be innovating on necessarily, but it's good to have that framework, because then you know what's happening in the 5-10 year time frame of where healthcare is going. So essentially, the U.S. has one of the highest spending per capita, but not any better outcomes. So that's where it's considered that we're wasteful. We're spending a lot of money on healthcare, and it's very good for the top level of care, which is why so many people come from other countries to get the best no stone left unturned, hardest complex cases, or people doing high volume things in the US, they come for it. High quality, but it's also, we're wasting it and we're not covering everybody who should be covered. And some other kind of graphs just to get you a sense of like what kind of problems are there at a macro level. Because healthcare can be approached from a public health, epidemiology, population health level, or it can be approached from the individual level. Most doctors think at the individual level. How do we treat the patient right in front of us? But then there's a lot of economists and people who in public health who think about, well, what are the main problems? Well, on a very high socio-demographic index, you can see that the communicable diseases or nutritional problems are actually a lower percentage of the problems inside the country relative to a low socioeconomic index, where you can see that things like diarrhea, HIV, TB, malaria are huge problems for those countries. And so that's a much different thing that you might not be exposed to if you haven't traveled to different areas. And so innovation in these areas can also be so impactful. So you can think about from a global perspective, but then you can always drill down to, from the individual perspective, walking into that clinic, what are they really experiencing? So that's another kind of even scoping where you may find your passion falls along that scoping in a certain way. Some people want to work more on the global health side. This graph is just showing like what kind of hours the doctors are putting in the US. Maybe that is of interest to the doctors in Hong Kong. So primary care and specialty care doing about the orange bar, 40 plus hours a week. And then you can actually see that telemedicine is really small in America still. Like people who are doing that regularly is just less than 1%. So it hasn't really penetrated, even though there's a lot of talk about this kind of stuff. And telemedicine has actually been around for a really long time. So why isn't it more? You should understand what are the barriers, whether is that a payment model problem, or is that probably not a technology problem necessarily, or is it a certain kind of technology infrastructure problem? Or is it more liability problem, malpractice issues, or is it, well, you can only treat certain things but not the majority. So it works very well for health, but not sickness, right? So you can think about the differences between preventative health and treating illnesses, actual things that need hospital-grade level equipment versus maybe non-hospital-grade equipment. So there's a lot of ways to slice the pie here in terms of who would then be your champions, to try out your new technologies, for example. Also just some stats about how the US divides up the costs from drugs versus hospitals. Hospital ownership, actually 60% are nonprofit. Like a Stanford is a nonprofit actually. So they can get tax deductions. But then in exchange, they take all patients. So they don't turn away the underinsured patients. Then, of course, the government-owned hospitals is like our Veterans Association, the VA, military hospitals. Then we also have for-profit hospital structures. And then drugs is actually a whole separate bin of where the reimbursement is and where the money is. So when we talk about Medicare, that's like patients over 65. Most of people are relatively healthy, except for a few sick people from early age. Then most of your spending on your health care is actually in your later years of life, particularly in your last year of life. So we have very complex ways of managing drug costs, PBMs, pharmacy benefit managements, how you do formularies and tiered pricing of copays of drugs. There's a lot that goes into that. So each one of these are 2 long lectures. That's probably too boring as well at this stage. So in summary, the healthcare choices in America, essentially, this is how our system works. If you're over 65, you're mandated to go on Medicare, even if you have a private insurance. Medicare becomes primary at 65. Your private insurance becomes secondary, your supplemental. So Part A, Part B. Part A covers hospital inpatient services. Part B covers physician fee associated services. Part D is covered drugs. And generally it's 80% paid for by the government, and then 20% copay that the patient owes. That copay can be covered by the insurance that you have as your secondary insurance. If you're under 65, then generally you're going to get some kind of private insurance, unless you're under 23 when you're covered under your, or 26, yeah, under your family plan, if your parents have insurance. And how that generally works is there's a monthly premium and a deductible. These are all new terms, but essentially, if you use your healthcare services, you'll know that you have to spend a certain amount up front unless there's a no deductible. And then the insurance will kick in to pay the rest, although generally there's a copay where you pay first and they pay everything else. Most people with private insurance are basically in an employed group plan, so people who have jobs, they're working. You can buy separate private insurance even if you're not working or independent contractor or something like that, but generally you won't get as good a negotiated rate and you'll be paying a much higher premium. Then there's Medicaid, which is to cover poverty level on your tax return. So if you're super, super poor, then there is a way to get covered. Although Medicaid pays very poorly for the services, so only certain doctors take Medicaid. And generally private doctors don't take Medicaid, but the public institutions, the training grounds, they cover Medicaid. And so that's how the system works, where people of medical student experience can take care of some people and take care of the relatively poor people. So there is that little bit of gap that was the people who were not employed, but they weren't poor enough to meet the Medicaid guidelines, in terms of qualifying. And that's where we tried to create an inexpensive state-run exchange called Affordable Care Act, which was mandated to pay in or you get penalized on your taxes. And now the idea was to get healthy people to contribute some small premium in order to make the whole insurance work. Because most people who are healthy and young were opting out. And so therefore only the sick people were opting in, like maybe you're a hemophiliac and you're getting these injections all the time and you're costing a lot of money but not enough spreading around the total insurance, and so it wasn't working. So Obamacare was created to try to fix that so that people wouldn't just go to the emergency room for their care. Because otherwise what happened was healthy people, if they got sick, they just went to the ED. Or maybe they went to their student clinic if they're still a student. But once they were graduated, then they didn't have that option. So that's the part that now, of course, with Trump America, we're having problems with in terms of keeping that funded and working in terms of the state-run exchanges. Then we have VA system, which is for everyone who has a service-connected percentage to the military, whether they're 100% connected because they serve full-time in the military or partially connected. Then you can go to veterans hospitals, which are salaried doctors, employees of the government. And then we have in relatively wealthier areas, metropolitan regions, sort of the private care that exists not by insurance. It's a supplemental self-pay or out-of-pocket kite model called concierge care, where you can get certain special services, meaning that 5 minutes with the doctor may become 30 minutes with the doctor because you're paying them either a retainer annual fee, or they still also charge insurance for specific tests and services, but to get access to sort of like a personal trainer or doctor, coach, that's like a concierge model. And then there's another model that's also working quite well right now, which you may not know about, which is employer-based benefits. So what's really happening in Silicon Valley is that the tech companies like Google, Facebook, Apple are actually providing, at first they're self-insured, and they can provide insurance, and they provide benefits where they contract out concierge services to be on-site, inside of the tech company, so that people don't have to leave work to go see their doctor. To make them healthier, more efficient, and happy, to do everything on-site, they have on-site medical or shared medical groups, like things like that. And that's not just for illnesses like cold and cough, but actually for stress reduction, massage therapy, help with your eye strain, things that they want you to be a happier, healthier worker, just like they give you nice meals and they do your laundry for you and they have on-site daycare and all the famous things that Silicon Valley, know about the very large tech companies have ever visited, you'll see that it's quite luxurious and quite lucky. So employer-based benefits. So see how complicated this is just to give you a cross-section of the various kinds of insurances. And then on top of that, the private insurance is divided into various kinds, like HMO, Health Maintenance Organization, PPO, Preferred Provider Organizations, EPO, Extended Provider Organization, HSA, Health Savings Accounts, and vision and dental are even a separate insurance. So medical falls under all those medical options, which have to do with how many doctors you get access to. So if you pay more, you can go to the doctor you want to. That's PPO. If you pay less monthly premium, then you have a restricted panel of doctors you have access to, like an HMO. And that's how they manage costs, because they sign up doctors based on their costs, actually, of how they manage their patients, and they can rank them, and then they can try to balance costs among who are the doctors that cost more money to the system or less money, and then they'll make them either on network or not on network. And probably the most successful model that we have in California is the Kaiser model. And the Kaiser model is called an integrated care model. So it's a form of an HMO, but the way this HMO works is that the insurance company and the doctors and the hospitals and everything are actually under one umbrella. Because normally before I showed you that the doctors are their own private group, the insurance is another separate group that contracts, negotiates with the doctors. But here, the doctors are salaried under the Kaiser model. And that way they can see the direct costs inside the entire system, because they do the surgeries, they do the medicines, everything is under one system. It's like being a nationalized healthcare system in a very small system. You know, only in California, NorCal, SoCal, although Kaiser also expands to the East Coast and a few other areas. So the famous names you hear about, like United Healthcare, Aetna, these billion-dollar companies, Blue Cross Blue Shield, they all keep combining, so they have more negotiating power and can maintain, you know, their profits. And then PPOs, and then finally the EPOs, like a hybrid between HMO and PPO, so you have a little bit more access, but still in-network, out-of-network complexities. Different costs. If you're in-network, it's less. Out-of-network, you have to pay more. It may not be 80% covered. It could be like 50% covered. And then this gets very complicated because the people inside and outside the network change too. So then that's not good for continuity. You may see one doctor at one time, but then now they're not in network anymore. So then people say the famous case is like you get surgery, your surgeon's in network, but your anesthesiologist is out of network. And so then you get stuck on the bill and you're like, what happened here? Why is she covering this? So there's a lot of frustrations in the system because of the complexity. And then finally, health savings account is for people who are relatively wealthier, and they save for, they get a tax benefit to put money aside into their own account to pay for their own expenses, generally the co-pays and things like what would be, you probably know about flex spending. But another way to save for your own healthcare for the future, so then that way you only tap it later in life when you get sick. So that's usually under high deductible plans, meaning that you cover almost all your costs up front because you're a single person that's making a high wage job that doesn't have to care a family, and so you can just save for yourself and you're healthy. Then HSA makes sense. So again, here's to just kind of give you an overview of the complexity of the cost sharing for, you know, we mentioned these terms, co-insurance, deductible, out-of-pocket limits, you know, co-pays. Generally, if you're not sick, you don't know about any of this stuff. But if you have, like, you know, a kid, or you have to go to the doctor yourself, then you start understanding what these things are. So it's kind of like a black box until you actually have to be involved. But essentially, deductible, how much you spend until the insurance kicks in, co-payments, every time you go see the doctor, you got to pay a little bit. That wasn't done to reduce the, you know, population from just going to see the doctor for any old thing. So if you make co-pays higher in the ED, then you'll be less, you know, you'll be more careful to actually go when it's a real problem as opposed to just, quote, abusing the system. So all this kind of stuff has evolved over the last, since the 1980s, in terms of the rise of HMOs and the pushback against them, then try and, you know, swing the pendulum back and forth. Where is the best spot, the sweet spot, to pay for things appropriately? Just to give you a brief overview of how doctors are paid, that's another very complicated system. So instead of understanding the payment by dollars, they actually use a unit called RVU for the Medicare payment scheme. That's because it's actually very hard to decide, well, how much is a brain surgery worth against an eye surgery? What dollar values will you give? So they created something called the RVU, that's called a work-related RVU, to try to adjust for complexity and time. Like how hard was it to be able to do that case? And how long does it take to complete one successfully of a routine case? Because again, they said what's routine versus that flat rate also covers for some are complicated and some are not. And they have to poll all these doctors. And supposedly, by kind of getting a blinded poll throughout the country, a committee called the RUC Committee can decide to go to CMS, which is the Center for Medicaid Services, to lobby what should their RVU be. Because essentially, the government always wants to pay less. The doctors want to protect what they think is a lot of training and a lot of hard work, And each specialty is fighting against each other a little bit because it's a zero-sum game. There's only one pot of money in the services in Part B, so if you give more to an oncologist, you'll be taking away some from an ophthalmologist. And that's only because when you try to balance a budget in the country, you've got X amount in military spending, X amount in social services, so retirement benefits, etc. And it's just dependent upon a country to decide what percent will go into the healthcare pool. So there's all these level of codes, and then there's all how did that code convert to a unit, and that unit is then $1 per unit, like I get decided based on the university. They'll say, I do this amount of work, and then you pay this $1 per unit, and that's different for different specialties, sometimes even different doctors, quite opaque, and a little bit challenging and complex. That's all you need to know about it. So essentially, you see how there's a lot of complexity here. But even in the RVU, you have to adjust for things. Like the RVU is actually adjusted for malpractice rates, practice expense, which is based on geography, and a budget neutrality adjuster, which they're always fighting every year because that has to do with the GDP of the country, because they're supposed to adjust for inflation and all these kind of things. How do you make sure that the doctors can stay in practice if they own their own practice relative to the overhead expenses for different regions, relative to what they get paid? Because again, it's not like the doctor says, like a lawyer, where you pay more dollar per hour if you're more expert and pay less if you're less. They want a flat rate across the country set by the government, and only that's for medical necessities, and only if there's premium or something that's out of pocket, then the doctor can set their own rate to what they want it to be. But in order to maintain access to care and not to use doctors getting together, causing collusion, getting the prices to go too high, and then nobody can get access, they don't want fixed pricing, so they set the fixed pricing. And then all the insurance companies basically go off what the government does. They either pay a little bit more than the government pays or pay a little bit less. And that's all based on how many lives covered they have, what they can afford, which doctors are in network, and these are all like actuary table adjustments and very complicated. Okay, I haven't put anybody to sleep yet on that. It's good, I made it. But I think this is the more interesting part in terms of what's coming down the line for healthcare. So the government realizes that the fee-for-service model is challenging to continue because basically for everything you do, the more you do, then the more you get paid. So there's unfortunately not a good aligned incentive in terms of taking care of sick people in the current system, because you're just going to keep doing more and more to them, especially as they get older and they're about to die, and unless they have advanced directive, it's full court press, and you spend like most of your costs in the last 6 months of your life. Depending on if, you go to the hospice care, then maybe the costs maybe go lower, so that's why they call them death panels, trying to get people to move into hospice, but then people are like, well, you're telling me to die, and so then there's a lot of ethical issues that start getting into play about, is this really about money, or is this about doing what's best for the patient, or what the patient wants? And so it gets very tricky there as well. So hopefully what they're doing to control costs is to bundle the payments. So therefore you get a certain amount of payment for everything, kind of just like an HMO used to restrict payments. So you had what we called it capitated payment at the time. But what happened in that system was that nobody wanted to take care of the sick people, and everyone just wanted the healthy people. And so how do you keep that balance where you only have a certain number of expensive people relative to the cheaper people? So if they do a bundle payment, and maybe it's to a medical system that's in an integrated care model, then they can offset the expensive specialties relative to maybe the cheaper specialties, because all of them will make different dollar per hour time, whether it's inpatient or outpatient. Well, did the surgeries all of a sudden become faster, but they were still paid the same rates from 5 years ago, so now they're overpaying for that. So the adjustment cycle to catch up to innovation is about 3 to 5 years. So what the government does, now that everything's digital, is they look at the coding usage. So when something spikes up really high, then they know that they pay too much for that because now it's overvalued. So if they cut that, they'll get more back on fewer people, so make a couple people unhappy, right? In order to spread it out to other areas. So it's a constant, just as things change in terms of how medical care is delivered, something pops up, they really reduce the price on that. And then it comes back down because then nobody thinks that it's valuable for their time to keep doing that because maybe something else new came up that's better. And then that's the constant cat and mouse race when it comes to innovation, price, and reimbursement. So the only way you can manage this is really to have IT in place, which is to have data so that you can see. Because before it was all paper and pencil, handwritten scribble, nobody could even read what was being done. And so the government really had to push to get everyone to be digital so that they can monitor fraud and abuse, because that's also a big thing they wanted to cut out, because that's, quote, easy money to get back into the system, as well as make sure what's overvalued or undervalued, they can appropriately adjust it in real time to what's happening in the country. So think of big data, think of how that's changing the marketplace. And it is definitely changing the marketplace for healthcare, but just that we move a little bit slower. Because people have to make sure there's not unintended consequences for every decision that you make. So as you can see here, is there a future for consumer health digitally enabling by using some of these technologies built off of the electronic records? So now we talk about deep learning, you can mine data, blockchain, now you can better share data, and distributed ledger, low-cost sensors for more non-invasive remote monitoring, so getting things that you don't get from inside the hospital because people spend 99% of their lives outside the hospital. And maybe all those decisions that are happening outside the hospital is actually what's really affecting what you could make more cost-effective inside the hospital. So we have all these cool new technologies like 3D printing, so really amazing prosthetics, even 3D printing organs and all kinds of things. New ways to visualize things to improve, maybe better targeted in your surgery, better education in your training. You try the operation before you do it on very complex cases, so you hopefully get improved outcomes. So you see how technology can really play a role in improving what the doctors are doing. Especially with Internet of Things, wearable sensors, now you're decreasing the price to collect data about your health, that if you measure at baseline, then you know a change from baseline, that's usually disease. This pathology is a change from your natural state. So the more you know about your natural state, the more you can earlier detect disease, because generally treatment works better the earlier you find it. If the more end-stage disease, it's more costly, and then you can't really restore to natural physiology generally at late stages. So that's why you see so much interest and discussion on this kind of stuff. How do you get better access, telepresence, not enough doctors around, you can use ways to communicate remotely, more robotics, trying to get more precise outcomes in surgery, but it's at a certain cost, and so you have to look at the cost-benefit ratio. Telemedicine applications, you're seeing an explosion of what are all the things that you can see easily collect the data and maybe approaching medical quality and maybe interpreted by algorithms that could then drive the price down of screening, because generally screening has always been not cost effective due to the human component that was involved in the collection as well as the interpretation of that data. Lots of things are happening in real time. People are even using things like social media to detect disease outbreaks, like on Twitter and things like this, so it's pretty cool what's happening. Obviously a lot of people know about deep learning now. It's always actually, mostly people are afraid of it, or they're talking about, is it going to take over their lives, is it going to move all your jobs, etc. That's the main discussions. I think people are always afraid of what they don't know, or afraid of change. So you can approach it that way, or you can approach it in the way of, well, how can it really help what I already do, or make me do what I do better? Gamification, things that can help with modifying behavior, things that are very challenging. Portable diagnostics, getting your data at the point of care. There's a lot of fancy, exciting things going. Even using CRISPR to target things more accurately, then you can make more diagnostic tests off that. Starting to do digital therapeutics, treating people straight through the phone, doing their psychiatry visits like Womata Health, managing, this is like coaching through the web or through apps to help you live your lifestyle better in order to reduce morbidity and mortality. So all this amazing tech to fix a broken system, right? Just remember, I do this on purpose to try to maybe lead you into a trap. Don't be that person who's the technology looking for an application. Just because these things are cool and they're of the moment right now, there might not still be the best way. Maybe the best way is just make a little J-hook on an instrument and that would solve the problem. It could be something very simple and mechanical. That could be the solution, but instead you're so focused on the high-tech way that you don't see that simple way. So again, we went over this already, identify, invent, implement. Hopefully you stay more on the side of identify at first. And just as a summary, this is kind of like the whole process, just to kind of re-emphasize what we're here to do for this week. You basically want to take a lot of needs, or as many as you can find, as many you can observe. You should have confidence in yourself. Like even when you're describing yourself and you reflect that you have you think that you're just good at one thing. That may not be true. There could be a lot of things that you just haven't really internalized and personalized to see that, and hopefully with talking to others, you can see what comes out based on those interactions. So you'll have a lot of interesting needs through your interactions with people that you haven't interacted with before. You refine it to a few needs that maybe ideally this is the kind of thing that we want. There's no solution that exists, or the current standard of care has a lot of problems. But it has a global potential market, and it's growing. And the mechanism is already known, so that your solution is solving something that there's no question that it'll work. There's no stakeholders who want to block you. Your intellectual property has freedom to operate. It doesn't really cost that much to get regulatory approval. It has a multi-billion-dollar potential. And you verified all the risk of how you distribute it and bring it to market on a business level canvas. See, if that was the ideal situation, certainly most things never fit the ideal. But now you're starting to understand how you check boxes so that you know which one is the one worth your time, worth working on. Put your best self in position to be successful. Just some statistics on where the Medicare spending is. We already went over this. Most of it is at the end of your life. Especially chronic disease also generates most of the cost of the system. This is the last slide. Is just talking about some comparisons of what healthcare was like in the 1975 to now. Of course, we didn't put inflation-adjusted dollars, but you can see that actually the number of healthcare jobs has gone up a lot. And we spend a lot more in healthcare these days. We even have super expensive drugs. Like people invent drugs that they're a cure, but it costs an enormous amount of money. Who should pay for that? And so now you again get into sort of ethical dilemmas, things that have never come up before in medicine, but come up now due to our technologies. Growing amount of GDP spent on healthcare, all these complicated systems to try to manage it, but each one of them eating a slice of the pie. So hopefully as you go through the journey of understanding the specialty that you're in, you can sometimes also get some clarity from the doctors explaining the healthcare system that they live in so that you know how you're going to maneuver. I'll take any questions if anyone wants to ask a quick question.
This is maybe not that quick, but how do you feel like the kind of shift towards value-based care is influencing digital health? Do you think it's have you seen a kind of resurgence of digital health solutions that fit into this value-based care model?
Yeah, so digital health is a super exciting area. That's why all the VCs at first were investing in it a lot. And then they realized actually it takes a long time to see the benefit. You can't see your outcome of your digital health in 1 year, let's say. Maybe in certain diseases or in certain specific areas you might, but it takes research proof. When you do things in a digital health paradigm, it's never been done before. So generally you're collecting data that nobody ever collected before. So it's hard to attribute what the value of that data is until you have longitudinal outcomes. So at the beginning, you collect something that's easy, that's low-hanging fruit. You try to make an association, with data mining, but you don't know causality. And so that's why the doctors still are sort of wary of implementing it right away, because you can't understand the value until there's a little bit more time collected. So what people are waiting for are like Omada Health type 2-year trials where they look at, well, what's the hemoglobin A1C adjusted endpoint, what's the weight adjusted endpoint for the group who got the coaching versus not through the digital health method, and then they can, be compared to more like randomized trials, comparison to gold standards, and you can add value there. So value-based care is super important because otherwise you're just making inventions that is nice to have sometimes, but maybe not a must-have even, if you put it in those kinds of terms. And nothing wrong with inventing some of those things as well, but it may not get the mass adoption if you're some kind of change agent that were affecting an impact of 100 million people, then you may need to do something else after that. So not to discourage you in any specific way or encourage you in any specific way, find what you think is the right sweet spot at the time of the current day, what's going on, what you're good at, and what you have access to. Okay, I think we'll move on now. Ms. Carrier.